Okay, well, thanks everyone for joining us today for this webinar. My name is Andrew Pinto, and I'm a family physician, a public health specialist, and a scientist based at the University of Toronto. And I direct a research team called the Upstream Lab. And it's my pleasure to host these webinars that are happening in collaboration with the College of Family Physicians of Canada. We're really delighted today for our second webinar in this series to have Dr. Anders Lenskjold, who's a Danish-trained physician with clinical experience in family, rural, and emergency medicine, trauma, and orthopedic surgery. He works as a medical informatics consultant with research groups and also with tech, and has particular expertise around machine learning in healthcare. He's interested in ways to advance healthcare using the appropriate applications of AI. And we're going to talk a bit about machine learning as one example today. Just a few housekeeping items. As you'll note, the session is being recorded and we'll be posting it online and on the Upstream Lab website. We do have a question and answer box, which we would encourage people to post questions in. We will be, after Anders presents, we will have a time where I ask a few questions and engage in a discussion, and then we'll open it to these questions. You can also, if you see a question that you like and that you think is something really of interest, you can use the thumbs up to upvote it so it gets higher on the list. We will also be, at the conclusion of this webinar series, we will also be collecting all of these questions that people have posed and trying to put together a frequently asked question section for the website. And finally, at the end of the webinar, we'll be doing a short post-survey questionnaire that you can complete, and it is mandatory for CME credits. So just to start with disclosures, so my disclosures are listed here. I don't have any commercial interests. We receive grants from a number of sources, as well as salary support. And the one main item is that I act as an unpaid advisor to a startup company. These are Dr. Anders' disclosures, and just where he has received funding and support as well. This program has received in-kind support from the College of Family Physicians of Canada in the form of a waiver of fee for the CME accreditation, and also the Upstream Lab has provided in-kind support in terms of staff time and coordination. I just want to use this opportunity to thank the Scientific Planning Committee, which includes some wonderful patient partners, Jane Cooney and Joanna McFadden, as well as a number of colleagues, and Rose Wang, who has done so much as the coordinator to support this, this initiative. So just to begin our discussion, we really want to begin by acknowledging the land on which we're meeting. So I'm based here in Toronto, and this has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. And I'll turn to Anders to talk about, he's based in Halifax.
So Dalhousie University is located in the Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq. We all treaty people.
And whenever we do a land acknowledgement, we want to, of course, acknowledge that this land continues to be the home to many Indigenous people from across Turtle Island. And we are very grateful for the opportunity to meet and work and live on this land. And also, to a practical thing with each of these webinars is I encourage people to take a look at the First Nations Data Center. This is a really wonderful organization that has a role around governance and particularly promotion of the OCAP principles. So please do take a look at that. So just to get us warmed up, we're going to start with some polls to see people out there who are joining us kind of some thoughts. So maybe Rose will let you launch that. So we'll give people a moment to complete these polls. So first, have you ever heard of machine learning? And then also, do you think you could explain it to friends or family members? So what people can have said is many people have heard the term, but not really sure what it is. Kind of a lot of people are in the sort of category in terms of being able to explain it, or maybe not really. So hopefully by the end of this, you'll be able to do that. So I'm going to turn it over to Andrews to start his presentation.
Thank you so much, Andrew. Thank you for the introduction, and let's get started so we can learn something about machine learning. And this will be on a high level, and just give you the terminology and the concept so you can go home and maybe watch some more YouTube videos on this and trying to understand it better. So the learning objectives for this presentation is first, define machine learning, how it's proceeded, and understand the difference between supervised versus unsupervised learning. Then the second one, describe how machine learning is currently applied and being developed for primary care. The third one, describe the problems surrounding use of machine learning and improve confidence in critically appraising machine learning tools. And the last one, evaluate how care, compassion, and continuity in family practice can be strengthened as these innovations are being introduced. So next slide. So we're going to start with a definition of machine learning. And I took this one from Oxford Dictionary. And I feel this one is capturing everything in one sentence. So it's the use and development of computer systems that are able to learn and adapt without following explicit instructions by using algorithms and statistical models to analyze and draw inferences from patterns in data. So it's an algorithm or a model that can learn, that keeps learning, keeps adapting. We don't tell it how to do it precisely, and then it will find the patterns in the data. So next slide, please. So here's one example that's being used in the west of Canada, also specific in Alberta. So it's Babylon Health by Telus. So they developed a tool that's a symptom checker. They say it's powered by artificial intelligence, and patients can plot in their symptoms, and it will sort of guide this patients to do what to do next, to call a provider, or if it's something that can wait, and see how it go. So next slide. So the big question in this setup is that, is the algorithm locked or adaptive? So a locked machine learning model is not learning anymore. It's been developed by the developers on lots of data, hopefully validated and get a good accuracy, but it won't learn anymore. Another idea is to do more adaptive models that can keep learning. So it will still learn while the users is using the app. What that means, we will need to know the hardcore truth to be able to tell the algorithm if it's the right answer or wrong, so it could keep correcting itself. So we're gonna start off with an hour poll on adaptive models. So the question is, are you comfortable with adaptive machine learning algorithms? Like algorithms that will keep learning while the users, providers, or patients are using the algorithm, the app, or whatever it is.
Maybe we'll just end the poll there and just share the results.
So there's most people say maybe. So we need to know a little bit more about what these algorithms are doing, and also what kind of conflicts there can be, before we go ahead with that. And it's a discussion in the community, and FDA in the States are still debating if we should have models that can learn on their own in the background. So we can close the poll and move to the next slide. So I couldn't find any concrete principle guidelines white paper on AI in healthcare in Canada, but I found this one from the government of Canada, and I feel this one could be used in healthcare as well as a guidance. So now we don't have a really hardcore paper, we can use this. So the first one is understand and measure the impact by the AI when we use the AI. So that's a really critical part. We need to know what kind of impact the AI has. So that means we need to have trials, we need to understand it, we need to do research on an AI. The second one is being transparent on how and when we're using the AI to disclose for the patient, to close for the provider, and everyone who are using these tools. And the third one is providing meaningful explanations about AI decision making and review the results and challenge the results to make sure that we have accurate and beneficial algorithms. The fourth one is being open as we can by sharing the source of code, which should be challenging when a company spends years, money, and resources on developing a tool. How would they ever share their resource code or source code? And also the training data. Now we come back to that. What kind of data has it been trained on? And the last one is provide sufficient training for, in this case, providers or patients. So that's why we're here today. So next slide, please. So in machine learning, we can divide most of the algorithms in these two main categories. So there's the supervised category and there's the unsupervised. So the supervised is typically have a label data, so we know what is the true, what is not. And it can be, for example, we know the blood pressure is this number, and then we can create the algorithm on behalf of that. Unsupervised machine learning has unlabeled data. So that means we don't know what we look for, but we want to find clusters where they are sharing some sort of patterns and association. And there's two different concepts. So when you see those two things, unsupervised, we don't know the truth. We're just going to explore. Supervised, we know the truth, and we can use it for prediction in the future. And next slide, please. So we're going to focus on two different models that are fairly easy to understand, or something that's relevant for healthcare industry. So the first one is a decision tree learning model. So these comes in classifications and regressions. So regression is that we get a number out, or we get some sort of range of numbers. What classification is that we get, for example, diagnose code or another task we need to do. So a category. These decision tree models, you've probably seen that throughout school and in your daily practice. So you're following them down, yes, no, above this number, below this number, and then you come down to sort of a decision, an endpoint decision. But we can actually make computers create those trees and compare them with the decision trees we have from guidelines to see if they are matching or if the computer found some association we didn't know about before. So I'm going to end on decision tree there and then move on to the next one. So the next one is the artificial neural network, and that's inspired by the human brain. So here we have the neuron where the signal travels down axon and then goes to the next neuron. And the next slide, please. And then you have the whole network of neurons in the brain that are communicating with each other. And they make like advanced patterns. And we want to assimilate that. So next slide. So here we have an example where we have some Chihuahua puppies and we have some blueberry muffins. And we want to make the computer find out what is what. So first, for this example, to make it very simple, we're going to do it in grayscale. So next slide. Yes, and then next slide. Then here we have the driver, and then the next slide, we have the muffin. So we want to make the computer, when we give it a photo, a picture, we want to make the distinguish, is it a Chihuahua puppy or is it a muffin? So next slide. So we're gonna take 9 pixels out of that photo. Of course, that is not the whole truth. A photo will consist of 100,000 millions or even more pixels. For this example, we're gonna do the basic. So we're gonna take 9 pixels out. And because it was black and white, we can say values of 0, they are white, and values of 1 are black, and then the grayscale is in between. So we're gonna make that into a vector, and then that vector will tell us this is a muffin. But this model means that if you create this model, you have to display the exact same pixels to get the result that this is a muffin, which is not very efficient because we want to show another photo of a muffin, and then the computer knows this is a muffin. Next slide. So that's why we can put in some hidden layers. So you still see the pixels as neurons, and then you have some sort of red lines that are connecting the neurons to some hidden layers, and then in the end to some output. Next slide, please. So here you see the full connection. So all neurons are connected to the next layer. And then that means that we can create some sort of combinations in between, like the human brain. We don't really know the path way in the human brain, but if you have seen 5 different apples and and then someone comes with a 6th apple you've never seen before, you still know it's an apple. And this is the same way we're gonna try to explain how neural networks work. So in this network of next slide, please, of weights, we add some weights in between. So those red lines are sending an input from one cell neuron to the other. And that input, we can put a little weight on, and we can put some bias on, and you can wrap it in some activation function. That means how the signal is transferred to the next neuron. And by doing that, we can kind of modify all the signals throughout the network and come up with a result. So next slide, please. So this is a very simplified way, but the way that this algorithm will learn is that you show the photo, it sends the signals throughout this network, and when you first do this, you put a randomized weights in, so the model doesn't know anything from the beginning if you work from scratch. And then you display a photo, and all the numbers go through all those weights, biases, and intervention functions, and then spits out an output. If that output is not fully correct, it goes back and do some back propagation to correct those weights slowly. And then you send the next photo in, and then it will slowly adapt to this whole network. And in the end, you will hopefully end up having an output that's correct. And you can show photos of the same item, but different photos, and we still know that this is a muffin. So this is a way, and those weights, it's just not photos. You can add in sort of data. You can add in blood pressure, you can add in A1C, and all those neurons down there. It doesn't need to be photos or audio files, but this one is like a basic model. There are more advanced models out there. If you jump to next slide. So when people talk about deep learning, that means we have 2 hidden layers. We can also just have 1 hidden layer, or we can have more, and we can accommodate, we can adjust how many neurons there are in each of those layers. So all of that is what developers are doing to make their models more accurate. Next slide, please. So here's an example from the clinical life. We have a photo of some sort of skin condition. The provider will take the photo, and then the model with the hidden layers in between will find out, and it spits out this is a melanoma, and then we know what to do next. So this is a way that we can help us diagnosing. So it's just one example. Next slide, please. So there are different modalities in AI that we can apply AI, machine learning, and data mining to. So there are sounds and voices, images, text, chatbots, and then data sets. So if you're going to go through the first one, sounds and voices. So there are some tools out there that can recognize voices and this speech, and then there are some tools that can listen and record a session between the provider and patient and knows exactly who tells what, and then make the chart review for the provider, and then the provider will review it in the end. But AI tools in the background have learned what kind of sounds they have to adjust for. And some tools are even developing while you talk. Will learn your accent, will learn what kind of terms you like to use. And then also in chart writing, you can dictate to a microphone and it writes the text for you. And when you use your stethoscope, it could also be an example where people with hearing disability, or if you just want to have a little bit more accurate output from your stethoscope, which is not maybe the most accurate tool at all, but it can certainly maybe trying to do it more precisely than what the human ear can do or assist. And then there's triaging. There are some systems where they implemented that at 911 call centers, where they can hear on the voice of the person calling a 1 center, and then tells us how likely is it that that person has a heart failure or heart attack. So there are some tools out there that use sounds and voices. Next modality, please. So there are the images, and you saw the one example with the skin condition. There's also the old tools that can recognize text and handwritten format. So that's really neat if you want to save some of your journals and get it into an electronic format, converted. The next modality. And then the text. So for when you write your chart note, and if it's unstructured, it means like if it's free hand text, it's not specific fields that are standardized, then you can use natural language processing, NLP, to go through your text, and then it creates a semantic meaning, and the computer knows what the text means. So you can, for example, use it for getting patient's medical history without looking through your whole journal, and it'll bring out the highlights. And this is a way to analyze free chart notes. Also in research, where you want to go through a lot of chart notes, which is not possible with human hours. Then there's the chatbots where you can help triaging your patients before they call your secretary, your admin person, and also help the patient to know what to do in between. And we see that from insurance companies, probably your mobile service center, and these are really neat ways of interacting with the patient before they even call you. So you won't get all phone calls, but you will get the ones that are most important. Then could also be providing medical advice, as we saw with the symptom checker, and also counseling and follow-ups. Let's say that you have recommended your patient to do a new diet or start up a new medication. It would be neat to know how the patient felt and how it goes, and then you can rely on this automatic work, and you get a report in the end. So you don't need to have the actual communication with the patient, but you get the final notes. Next slide, please. And then there's the data set, and that's what I've been working most with. It's looking at the EMR and EHR data sets and trying to find patterns and clusters, and also trying to predict some values for the future use. And we're doing some work at Dalhousie Department of Family Medicine, where we're trying to predict some values and predict some high-risk patients during the pandemic time, and see how we can apply that. And then using machine learning, because we have so many variables and the data sets are massive. Everything is relatively, but it would be hard for a person to go through all those thousands of notes and variables there are in those bigger data sets. Yeah, next slide, please. So before we can even do this, we have some ethical considerations we have to keep in mind. One that's really important, and especially here in Canada, is the minority bias. And if you train your data set on the majority, you will only know what the majority would do if you use the algorithm. And if you have to make sure the minority is represented, and also that it's represented in the same ratio as in real life. Don't represent just the minority with the extreme cases, because then the algorithm will only predict extreme cases if it knows it's a minority group. So it's important to make sure you have a larger representation to get algorithm that do a fair prediction, and you don't end up with minority discrimination. Then there's the reliability and accountability. So if an algorithm is predicting something or making a suggestion, and that means that the patient got worse or even a fatal incident and patient did not survive, who do we blame? And that's when the next poll comes up. So who should be held responsible for malpractice resulted by an AI algorithm? So let me see what you think or suggest. So most people suggest that it's the health authority that approved the AI algorithm. So this is a big question, and we don't really know because there's no concrete paper on how Canada is gonna react in these situations. So we can say that on the AI developer side, they have to make sure that we have a good training set that represents the population, that is well populated, and in primary care, we all know that we don't enter all information in the EMR. We only enter the ones that are relevant. But for an AI algorithm, that might not be enough because we are doing some critical thinking while we enter the data, but the AI algorithm does not have that critical thinking. So to create better data sets, we also need to enter the information that seems not relevant for us, but could potentially be relevant in those computation. And then the healthcare is also, and then the patient. Some voted also the patient. We need to teach both providers and patients how to use AI, so everyone has an idea and can consent to use the AI. So the next one, we can close down the poll. Thanks, Andrew. So the next one is confirmation bias. So some of those models predicting something, and it's predicting what you already thought, and there can be some sort of bias in that. And also that bias in data set, as I mentioned, we don't record everything in the primary care data sets, and it might not be standardized. So that's a huge bias for that. And then there's the transparency. People talk about the black box, and you saw the hidden layers earlier, where you call them hidden because we don't really know, but we actually know a little bit. We know all the weights in the end, and we know how the numbers are going through all the neurons, even the hidden ones. They're called the black box, and there are some some tools where we can actually go back and trace back, some reverse engineer, and find out what are the features that were dominant in predicting this case. So the black box is not that black. It might be more gray. So that's we need to keep that in mind. But definitely, it's hard for a provider to explain how we came to result if they don't know the calculations in between. And then here, there's a little list. I'm not sure if it was shared, but there were some good papers where you can read some of those parts here. And then there's also a YouTube video that's explaining the basic levels, but it goes into more math. I didn't want to bring in the math part in this presentation, but definitely if you want to see more of the math, you can click on that video. Thanks.